My name is Amro Aglan, and I'm a second-year internal medicine resident at Leahy Clinic in Burlington, Massachusetts. Today I'm presenting a case of amiodarone-induced acute respiratory distress syndrome after atrial fibrillation catheter ablation and Watchman device implant. Amiodarone-induced pulmonary toxicity is a known complication of amiodarone therapy. Although interstitial pneumonitis is the most common presentation, rapid progression to acute respiratory distress syndrome (ARDS) has been described in association with perioperative loading of amiodarone in cardiothoracic surgery. We here present a case of amiodarone-induced ARDS after a non-surgical cardiac procedure and relatively short period of low-dose amiodarone use. Our patient is a 7-year-old female who was transferred to the ED due to progressive dyspnea. 2 months prior to her presentation, she underwent successful pulmonary vein isolation and Watchman device placement for persistent atrial fibrillation. Post-procedure, she developed atrial fibrillation with rapid ventricular response requiring IV amiodarone load and was transitioned to oral amiodarone 200 mg daily. 1 month after, she presented with dyspnea and CT showed bilateral ground glass opacities thought to be secondary to acute heart failure, for which she was diuresed and discharged on furosemide. On current presentation, 1 month after, she was noted to be in severe respiratory distress with bilateral near-complete lung opacification on the CT. She was started on continuous positive airway pressure, given high-dose IV furosemide, and home amiodarone was held. However, her respiratory distress worsened, requiring intubation. Bronchoscopy was performed and bronchoalveolar lavage ruled out hemorrhage, malignancy, and infection. However, an increase in percentage of neutrophils and presence of foamy macrophages were shown. Given timeline of events and BAL results, a presumptive diagnosis of amiodarone ARDS was made and high-dose corticosteroids were started. 2 weeks later, patient was successfully extubated and discharged. Subsequent outpatient follow-up at 4 months revealed no recurrence of symptoms and complete resolution of radiographic findings. In Figure A and Figure B, we can see chest X-ray and CT 1 month after starting amiodarone showing bilateral ground glass opacities. In Figure C and Figure D, we can see chest X-ray and CT 2 months after starting amiodarone, which is our current presentation, showing progression of opacities in a similar pattern to previous imaging. Amiodarone pulmonary toxicity should be suspected in any patient taking amiodarone with new respiratory symptoms or infiltrates on imaging. Despite its known association with cardiothoracic surgery, only a few studies have reported amiodarone-induced ARDS in patients who have undergone non-surgical cardiac procedures. One proposed mechanism is related to high concentrations of supplemental oxygen forming toxic free radicals. Diagnosis can be challenging and bronchoscopy may be required to rule out other possible causes. Treatment includes high-dose corticosteroids and outcome can be favorable if diagnosed early. In conclusion, prompt recognition of amiodarone pulmonary toxicity is needed to prevent clinical deterioration. Similar to cardiothoracic surgery, cardiac procedures can increase the risk of developing amiodarone-induced ARDS and warrant further research. Thank you.